Okay, I think we'll get going. Thank you everybody for joining us today this for the second webinar in our Equine Imaging Masterclass series. Today we've got one of our great radiologists, Josie Faulkner, presenting pinpointing problems in the equine proximal phalanx. Josie has been working with VetCT for over a year now. Prior to that, she worked in several private clinics in the UK and Australia and completed her diagnostic imaging residency at Ghent University. Currently, Josie splits her time between Murdoch University and VetCT, and she recently completed a PhD on sagittal groove disease of the equine proximal phalanx. And then I'll just introduce a little bit about VetCT as well for those who don't know. So our equine team here at VetCT, we've got a great team of equine radiologists here to report any images that you take out in the field. So pre-purchase examination, x-rays or any neck x-rays, anything that you just would like a second opinion on, or routine MRIs, CTs, anything basically that you'd like a second pair of eyes on. The team here and full of all sorts of expertise ready to report for you. We operate off a very easy to use online platform, so image send and communication with the radiologist is all really straightforward. If you'd like to hear a bit more, please feel free to scan the QR code at the bottom of the screen or just drop us an email after the webinar and we'll answer any questions that you've got. And then just a few housekeeping things for the webinar. The webinar will be approximately an hour long, made up of 45 minutes of Josie's presentation and then a 15 minutes question and answer session. So please hold on to any questions you've got until the end of the webinar. And if you could then just click the Q&A box at the bottom of your screen to type any questions you've got for Josie, and we can go through those at the end. And finally, the webinar is going to be recorded. So if you have to drop out at any moment, we'll send the recording over to you in a couple of days' time. So for now, please just enjoy Josie's presentation. Over to you, Josie. It looks like your screen's just... That's okay.
Is that back on the screen now?
Yeah, that's back on, yeah. So when you're ready, yeah. Perfect.
Great. Hi, everyone. Today we'll be focusing on the proximal phalanx, or P1. This is a long bone that articulates proximally with the third metacarpus in forelimbs and the third metatarsus in hindlimbs, and distally with the middle phalanx, or P2. In this talk, we're going to run through the identification of pathology in the proximal phalanx on radiographs. We'll discuss the clinical relevance of the imaging findings and also talk a bit about the types of pathology that may be undetectable or underestimated on radiographs. Here we have a sagittal plane CT reconstruction, as well as a dorsal plane reconstruction of the proximal phalanx. And as well as that, a 3D volume rendering of the bone, all of which can help us appreciate its anatomical features. Let me just put this into a mid-sagittal plane and sort of midway through here. So from these images, we can see that the bone is wider proximally than distally. There are medial and lateral palmar or plantar eminences present at the palmar or plantar aspect. At the proximal aspect of the bone, we have the medial and lateral foveas or glenoids, and in between them, the sagittal groove. The medial fovea is always a little bit wider than the lateral one. There are numerous attachment sites for ligaments and tendons on the bone. At the medial and lateral aspects, we have the collateral ligaments attaching. And then on the palmar or plantar surface, there are multiple roughened regions that represent ligamentous attachment sites. This large triangular one is called the trigone. So ligaments that insert in this region include the oblique distal sesamoidean ligaments, the digital annular ligaments, and the palmar ligaments of the proximal interphalangeal joint. And then not to forget as well that at the dorsoproximolateral aspect of the bone in the forelimb, the lateral digital extensor tendon attaches here. One special feature that we should mention is that there is often a nutrient foramen running through the diaphyseal cortex. Here it's present in the dorsal cortex, but occasionally it can be present at the palmar or plantar cortex. And it's important not to mistake this for a fracture in radiographs. Looking at the distal aspect of the bone, we have a condyle with medial and lateral convex parts with a shallow axial groove in between. If we look at the palmaro-distal aspect of the bone, there is a concave defect in the sagittal midline. This is an important feature to know about, as it can be mistaken for a cyst-like lesion on radiographs if it looks quite pronounced. So let's have a look at how you can go about evaluating the proximal phalanx on radiographs. Here we have some normal radiographs of a 3.5-year-old warm blood. Personally, I like to start with evaluating the soft tissues and look for any regions of swelling. And then I move proximal to distal, assessing both the bones and joints. Proximally, I look at the articular margins of the fetlock for osteophytes, osteochondral fragments. I check the joint space width. Then I have a look at the subchondral bone of the foveas and the sagittal groove. Quite often, you have the ergot superimposed over the sagittal groove region in the DP projection, which can cause some artifactual increased opacity. To try and get rid of that, you can try taking slightly different proximodistal angles or cut it off partially with a hoof knife. Moving on distally, in this horse, we have a physeal remnant present. And then I assess all the cortical margins. In this bone, there's quite often some enthesophytes present, especially at the palmar or plantar aspect. In this horse, we can faintly see the nutrient foramen in the dorsal cortex. Looking at the trabecular bone, we have a relatively more lucent medullary cavity in the center, which can vary quite markedly in size and shape. And then distally here in this horse, we have an ill-defined sagittal lucency, which represents that normal indentation that I just showed you. And then finally, at the distal aspect, I look at the articular margins of the proximal interphalangeal joint, as well as the subchondral bone and joint space width. So that's a normal one. Now we can move on to the possible pathologies. Clearly, here we have something rather severe. It's a foal, as we can see from the open physes, and it has recently sustained a comminuted, markedly displaced fracture of the distal diaphysis of the proximal phalanx, with transverse to oblique fracture planes and intra-articular communication with the proximal interphalangeal joint. This pathology is not particularly difficult to pinpoint, and to be honest, you probably don't need to be a vet or a medical professional to be able to identify it. And as such, we are going to focus mainly on more subtle pathologies for the remainder of the webinar. Let's start with a very common one, osteoarthritis. We encounter it in our patients, and it's quite variable in severity. Here's a very mild case with small osteophytes at the articular margins of the fetlock and proximal interphalangeal joints. Now focusing on the fetlock, here's a slightly more pronounced case with osteophytes that are a little bit bigger, and there's possibly some minor narrowing of the joint space at the dorsomedial aspect of the joint. And moving on to more pronounced pathology, the osteophytes are getting much larger. The joint space narrowing is a little bit more pronounced. And we can start to appreciate some subchondral densification and even possibly a region of subchondral osteolysis. In this case, there's also a small osseous fragment at the dorsal aspect of the joint. Looking distally at the proximal interphalangeal joint, here's one towards the milder end of the spectrum. Again, we have the development of osteophytes at the articular margins. This can progress to larger osteophytes. In this case, we also have some minor joint space narrowing and subjective subchondral osseous densification. And in very severe cases, this is what we end up with. Here we have marked periarticular new bone formation, joint space narrowing, or even obliteration in some areas, with mixed regions of subchondral osseous densification or sclerosis and osteolysis. This is most pronounced at the lateral aspect of this joint. So what is the clinical relevance of these changes on radiographs? Well, mild osteophytosis is often present in horses with no clinical signs, but saying that, the more severe the changes, the more they tend to be associated with a lameness or increased grade of lameness. The main clinical conundrum that arises potentially is when you find mild osteoarthritis in horses with higher grades of lameness without any other clear findings. It can be quite frustrating. You may, of course, have another source of pain that's causing this lameness, but significant pain can also be coming from these joints. It's just not so clear radiographically. That can be because the pain is associated with the inflammatory synovitis or subchondral bone pain, rather than the osteophytosis. If there is any concern that the severity of the OA that you're seeing on the radiographs doesn't explain the lameness, then intra-articular anesthesia can be performed to assess how much residual lameness is left after blocking, with further blocks then performed as necessary. Of course, there's the caveat that you don't want to be blocking horses that may have an undetected fissure fracture, so choose your cases carefully. The other option is that further imaging can help to reveal pathology that can't be appreciated on radiographs. The modality can be chosen based on your differential diagnoses, the availability of modalities in your area, and also the financial constraints of the clients. So, for example, you could use ultrasonography if you suspect there might be a soft tissue lesion. Here on the right, we have some MRI images showing bone edema-like signal in the proximomedial aspect of the proximal phalanx in this horse, and also to a lesser extent also involving the third metacarpus. We cannot see these type of physiological changes on radiographs, which is why they're so useful for diagnosis. We'll take a quick deviation just to say that the lucky thing for horses that do have severe pathology of the proximal interphalangeal joint in particular is that arthrodesis has been shown to be a fairly effective and safe method to treat injuries in this region, chronic ones especially. A recent meta-analysis showed that the procedure is associated with a high survival rate and fairly low surgical site infection rate. And overall, the rate of return to soundness for intended use is moderate. Let's move on to some subchondral bone pathology that is appreciable on radiographs. In this webinar, I have included some cases for you to briefly review on your own before I run through the main findings. So you have 15 seconds for each case to have a look and see if you can identify the pathology. So here we have a 13-year-old warm blood mare who's been lame in the left forelimb for 2 months, 3 out of 5. A palmar digital nerve block leads to a 50% improvement. An abaxial sesamoid nerve block leads to a 90% improvement. And there is no response to intra-articular anesthesia of the fetlock. So here is your 15 seconds. So our main findings are that there is some soft tissue swelling and emphysema from the recent nerve blocks. We have some minor osteophytes. And then there is this ill-defined ovoid subchondral lucency in the medial fovea of P1 with some surrounding sclerosis. In this case, some radiographs were also taken of the right forelimb, and it showed that there is a similar lesion in the medial fovea of that limb. So here we have evidence of a bilateral subchondral demineralization pathology, which is more consistent with a chronic overload injury rather than a bilateral developmental lesion. These sites can be quite painful, but interestingly, this case didn't block to the fetlock, and this is most likely because subchondral bone pain isn't always blocked out by an intra-articular block. It's important to pick these up because occasionally they can progress to a stress fracture under conditions of high loading because the mix of sclerosis and porosity in the area makes the bone weaker at that point. Here is another case for you. It is an 11-year-old quarter horse gelding, 3 out of 5 lame at the trot, no lameness evident at the walk. It has been on stall rest for 8 weeks, and nuclear scintigraphy has shown that there is increased radiopharmaceutical uptake at the proximal aspect of the left forelimb proximal phalanx, as we can see here and here. Here are the radiographs, and here's your 15 seconds. So looking at the outer edges of the radiograph, we have some soft tissue swelling at the dorsoproximal aspect of P1, or the proximal phalanx. At the cortical margins, there's a moderate mixed periosteal reaction present at the dorsoproximal aspect, which is fairly well mineralized and well defined with an interrupted palisading and smooth solid component to it. There are some small osteophytes at the margins of the fetlock joint. And then when we look at the subchondral bone, there is a well-defined ovoid to triangular subchondral lucency that's present in the sagittal groove of P1, with a wide zone of surrounding densification. These well-defined borders and surrounding sclerosis are fairly typical for an osseous cyst-like lesion. In this case, it's unclear whether the lesion is in communication with the joint, but there is marked surrounding remodeling, which indicates that the bone is responding to stimulus, so typically a degree of instability or alteration of forces in the area. Osseous cyst-like lesions can occur in numerous locations. Here we have a subchondral cyst-like lesion at the distosagittal or distoaxial aspect of P1, located here, and we can see it here. The key to differentiating a true lesion like this from the artifactual appearance of a cystic lesion, as I was explaining earlier, in the same location, is that we can identify it on the LM projection. They're not always in the sagittal midline. They can also be medially or laterally located. And here we have a very large cyst-like lesion in the distal lateral aspect of the proximal phalanx in this horse. Nicely also appreciated in the oblique projections. In young horses, well-defined lucencies representing osseous cyst-like lesions can be a form of osteochondrosis, and that can either have a developmental or traumatic etiology. They can also develop in older horses secondary to a subchondral bone injury. So what starts as a site of demineralization can progress into a cavitary lesion. Their clinical relevance is variable. Some are an incidental finding. Those that are located in the axial or sagittal midline are generally considered to be of lower risk in the proximal interphalangeal joint. Features which are indicative of a higher risk are the presence of articular communication and concurrent osteoarthritis, as well as the degree of surrounding sclerosis and periosteal new bone. Intra-articular diagnostic anesthesia can be used to verify the clinical relevance of these lesions in some cases. However, it's not always reliable due to this subchondral bone pain component. Further imaging can help evaluate the lesions, and this would include things like CT arthrography to determine the extent of cartilage defects and articular communication. And then modalities like MRI, scintigraphy, and PET can show the physiological processes that are actively surrounding the lesion. On the topic of subchondral bone pathologies, a special mention needs to be made about the subchondral bone of the sagittal groove. There has been an increasing amount of attention paid to lesions in this region as we recognize its importance. So on the left, there is an example of a short fissure with some associated surrounding sclerosis affecting the sagittal groove. And if you look closely, you can see that there is some minor demineralization adjacent to the fissure. We do see these short fissures of a couple of millimeters in length quite commonly, and it's thought currently that many of these represent incidental developmental defects. But in this case, the concurrent thickening of the subchondral bone plate and these faint lytic lesions are more consistent with a chronic stress-related bone injury. In this type of case, diagnostic anesthesia should either be avoided or could be undertaken, but with extreme care, as these changes present an increased risk of catastrophic fracture. Might also be a good idea to take a DP projection of the contralateral fetlock, since sometimes the pathology is bilateral. And one way to avoid doing any diagnostic anesthesia is potentially to refer for advanced imaging to get some more information about the pathology. The case that's on the right shows a larger region of lucency in the sagittal groove, with a moderate amount of periosteal new bone formation located at the dorsoproximal aspect of P1. Incidentally, there's also marked narrowing of the medial aspect of this joint. This type of periosteal new bone formation in this location should always be taken very seriously, as it has been shown to be one of the prodromal changes that is present in horses that develop sagittal plane fractures. And the reason it's important that these sort of lesions are detected early and managed appropriately is that they can progress into complete sagittal fractures, especially if the horse continues working at the same level. So here's an example of a horse with a complete minimally displaced sagittal spiraling fracture. You can see the amount of sclerosis that's surrounding this sagittal groove region. CT was undertaken in this case and was useful for clarifying the fracture configuration, comminution, and the degree of articular involvement. So these subchondrolytic changes that can occur in the sagittal groove often appear to look like a cyst-like lesion on DP radiographs, but in reality, they normally, or most often, represent dorsopalmally or dorsoplantally oriented lines of demineralization. These lesions are sometimes singular and sometimes double. And in 2015, there was a really nice paper published which described the CT appearance of sagittal groove fissures in sports horses not used for racing. And it was shown that in 54% of these horses, there was this classic appearance with double parallel lines of osseous resorption. These linear demineralizations sometimes also have the short fissure line in between them. So these were all non-racing horses. Typically, race horses tend to have their resorptive sites located a bit more dorsoproximally, whereas sports horses tend to have them more in the middle third of the sagittal groove. The decision of whether to go for a CT or MRI for further evaluation can be a bit difficult. While CT shows densification of bone, demineralization, and thin fissures really well, and it's also very useful for surgical planning, MRI also has the benefit of being able to determine the degree of bone edema-like signal that's associated with the lesion. Its negative points are that MRI doesn't always have the resolution to be able to visualize thin fissure lines, especially if it's a low field MRI. So when trying to make this decision, you need to think about the specific features of each case before deciding. Here is an example of an MRI showing an incomplete articular non-displaced sagittal fracture of the proximal phalanx surrounded by extensive bone edema like change. Let's move away from the subchondral bone now. Here is another radiography case for you to look at. It is a 3-year-old thoroughbred colt. It's had a lameness for 2 months and is currently 1 out of 5 left hind at a trot. It has had screening radiographs taken of the fetlock tarsus and stifle, and OA has been identified in the distal intertarsal joint. But I'm interested about what you think of the proximal phalanx. So here we have a very well-defined, smoothly marginated, semicircular to ovoid osteochondral fragment at the dorso-proximo-medial eminence of the proximal phalanx. This could be intra-articular, intra-capsular fragmentation, or it could be some dystrophic chronic mineralization within the joint capsule. This lesion is quite chronic in nature and is likely to have been present before the onset of the lameness 2 months ago. However, it could be contributing to the lameness described, but it would be best to use diagnostic anesthesia to confirm this. You could also use ultrasound to verify the exact position of the lesion and whether it would be amenable to arthroscopic removal. Osteochondral fragmentation occurs with variable sizes and shapes of fragments. Sharply marginated fragments tend to be acute and traumatic in origin, while rounded ones represent either osteochondritis dissecans lesions or chronic chip fractures. For those that occur at the dorsoproximal eminences, they are most commonly located medially, but can also be present dorsolaterally or even biaxially. And this has been shown to be true for thoroughbreds as well as warm bloods. The surgical removal of dorsoproximal fragments is very commonly performed. This is sometimes done in order to improve the appearance of pre-purchase radiographs and also to prevent the possibility of a future lameness occurring due to them. And due to this, it's actually very difficult for us to predict what proportion of horses with these lesions would become symptomatic if not treated arthroscopically. Osteochondral fragmentation also occurs palmally or plantally and can be present axially or abaxially. So the axial osteochondral fragments are often articular, while the abaxial ones are often extra-articular, but it does depend on the particular configuration, shape, and size of the fragments. The axial fragments are thought to occur due to an avulsion fracture of the short sesamoidal ligaments or OCD. And the abaxial fracture or fragments are thought to be either traumatic fractures or in some cases could be developmental. It's not been definitively confirmed yet, and it's possible that both situations exist. So the non-articular abaxial fragments are generally regarded as being amenable to conservative therapy. And the axial fragments are often also clinically silent, but they may occasionally result in a chronic effusion and a mild lameness, which would necessitate their removal. Here is your next speedy radiography case. It is a 12-year-old warm blood gelding that has had increasing swelling of the left forelimb pastern. The left forelimb lameness switches to a right forelimb lameness after a palmar digital nerve block. The lameness then switches back after blocking the other limb, and then the left forelimb lameness completely blocks out to an abaxial sesamoid nerve block. So here is your 15 seconds. So this horse has moderate to marked soft tissue swelling at the palmar and medial aspects of the pastern. It also has quite marked new bone formation at the palmar aspect of the bone that is most pronounced at the palmar medial aspect. These changes are consistent with an enthesopathy, likely involving several ligamentous attachments. New bone formation in these regions fit with the enthesis of the oblique sesamoidean ligament, the proximal attachment of the distal digital annular ligament, the proximal and distal attachments of the proximal digital annular ligament. This is a very complex region, and there's a very handy resource in the clinical radiology of the horse textbook, which can help you with your interpretation of which ligamentous attachments might be involved. The important thing to think about is that these enthesophytic changes may be associated with ligament damage, especially in cases where there is soft tissue swelling detected. So these changes can be of variable clinical relevance. We do see them fairly commonly. You can get some more information about them and the surrounding soft tissue structures with further imaging. There are some really excellent publications from the team at Cirral, which describe ultrasonographic techniques for this region with nice images of normal and abnormal anatomy. And MRI is also very useful. Here is an example of thickening, desmopathy in the region of the distal digital annular ligament and or the lateral palmar abaxial ligament of the proximal interphalangeal joint. So I thought we would finish off this webinar with a few unusual case reports, just to remind ourselves that occasionally it's not something typical, although these would be very unusual. So on the left are some images from a case report of a horse that had a severe lameness that couldn't be controlled with pain relief. There is moth-eaten osteolysis in the cortical, trabecular, and subchondral bone, with a moderate irregular periosteal reaction adjacent to it. And this was diagnosed as a primary ossifying fibroma. On the right, there is a LM radiograph of an Arab barb horse used for a sport called taburida, which involves a sudden stop after a fast gallop. And that causes marked hyperextension of the fetlock joint. In this radiograph, there is a large cauliflower-like osseous proliferation at the dorsoproximal aspect of the proximal phalanx. And on histology, this was shown to be a base of cancellous bone with a cap of cartilage, which would be consistent with an osteochondroma. Here's a list of references that I have used in my presentation. I hope that you have enjoyed this run through of proximal phalanx pathology on radiography. And I'm happy to take any questions if you have any. I don't know if there's any in the Q&A
No, I
box.
can't see. Thank you very much, Josie. That was really great. I can't see any questions yet. We'll just hold on for a couple of minutes. But if any of you come up with any, suddenly any questions that occur to you after the webinar has finished, please feel free to drop us an email with them. Josie will be happy to answer. And then maybe Josie, if you don't mind just going over to the next slide, there's just a couple of QR codes just that are worth scanning. See, the one on your left is just if you'd like any more information about VetCT, and the one on your right is just to sign up to the next webinar, which is in March and will be hosted by Dr. Rachel Murray and Dr. Lucy Meehan. And you can find out more by scanning that QR code. I've just had a comment from Sean Rooney just saying just a thank you for that and your time. So thank you very much, Sean. That's always nice to hear.
Thanks.